So this is a case of a young girl who had a CAKUT, and she developed a severe renal failure associated with several other complications during the course. So this was a 3-year-old girl who was averagely grown, 10 kg and 94 centimeters height. She became acutely sick and developed high-grade fever for lasting for 3 days. This was associated with some abdominal pain. She had some watery loose stools, and gradually she became more sick. She had reduced oral intake. The urine output started reducing. She was lethargic, but was not vomiting actively, and there was no history of eating outside food. So her local pediatrician had done few routine tests initially, and it looked like a viral initially, but CRP was elevated. Creatinine was, to begin with, was near normal, and dengue, malaria, common infections were ruled out. But blood culture had grown Klebsiella. Urine did not show any significant pus cells or any culture growth which was identified, and hence she was started on cefixime by the local pediatrician on OPD basis. But she soon became more sick and became drowsy. The urine output almost became like nil, negligible, and she basically was admitted at another hospital where she was found to be dehydrated and was in hypotensive shock and was hospitalized. At this point, which was around 2 days after the initial presentation, her creatinine had significantly increased from zero point 0.5 to 2.5, and there were a lot of electrolyte abnormalities as could be seen here: hyperkalemia, severe acidosis, and a CRP which was quite high. Ultrasound which was done suggested a single solitary functioning kidney with uh, changes suggestive of pyelonephritis, and ultrasound itself was showing areas of scarring between the poles of the kidneys. A Doppler was also done because of the severe renal failure, and it suggested renal vein thrombosis. So the parents later on shifted the child within the next few hours to our hospital at Girgaon, and we began the next line of management for her. So to begin with, we took a detailed history of her regarding the antenatal period and period so far. So in the antenatal period, it was found that she had from the papers it was found out that she had fatal ascites, and there was evidence of polyhydramnios where paracentesis was done. And that time itself, a left small kidney was identified with cyst. At that time, the right kidney had mild hydronephrosis, hydroureter, and there was a cystic lesion in the pelvis, which was later on termed as hydrometrocolpos. So it was basically a fluid-filled vagina in the antenatal period. She was delivered before term at by LSCS in view of the increasing ascites. The maternal steroids were given, and because she was born preterm, before delivery, before term, she had a low birth weight. Post delivery, she had a significant abdominal distension, and after delivery, when they examined, she was found to have a single rectal opening, and the vagina and the urethra could not be identified. And when they did the ultrasound and the imaging, they found a single stomach gas shadow, which was suggestive of a gastric outlet obstruction. So this she was basically labeled as a cloaca malformation. As you can see that there is some obstruction in the digestive tract, and even the reproductive and the urinary tract are not properly delineated. So this is a case of a cloaca malformation. And then after delivery, which was in a different hospital, she on the day second of life, she underwent certain surgeries in the form of a jejunostomy, gastrojejunostomy for the gastric outlet obstruction, and vesicostomy for the bladder, and the colostomy to decompress the intestines. So this was the initial surgery which was done, and few months later, she underwent further more surgeries for the cloaca, so the form of a cloacal reconstruction. And initially, the anorectum was separated from the urogenital sinus. Vesicostomy was closed, and later on, for a few months, she was on suprapubic catheter, which was left in situ. And later on, after vaginal reconstruction and colostomy closure, the suprapubic catheter was later on removed. So this was basically the surgeries done earlier. And when she presented to us, she was basically self-voiding. She was having regular stools on daily basis, and did not have any other uh, indwelling devices or any other surgeries which were yet to be closed. So the further course from that time till the time she presented to us was that she had multiple UTIs, and initial DMSA scan which was done, although it showed normal, but a subsequent scan which was done few months prior had shown multiple renal scars, and there was only one kidney which was now functioning. The left kidney had completely regressed. It was not even identified. So she had practically only a single right functioning kidney. MCU, which was also done, other hospital suggested there was no VUR, and bladder, which was labeled as normal. She was all this while on trimethoprim prophylaxis, and the right kidney was growing well, and it showed compensatory hypertrophy, and there were no other vertebral or skeletal anomalies. Now, why do we need to know this? Because cloacal malformation, as we would know, is a condition where the digestive, the reproductive, and the urinary tracts, they all merge together and they exit through a common opening. And this is supposed to be a very severe type of anorectal malformation and seen exclusively in the female patients. It's usually not well diagnosed before birth, and the only antenatal evidence of a cloaca would be in the form of a fluid-filled vagina or a hydrocolpos. So that should alert to us that it could be a cloaca malformation. And post-delivery, the examination of the perineum becomes very important, because unless you find the proper openings, we may miss such condition of a cloaca. So usually in such cases, we find a single common opening behind the clitoris, and that confirms the diagnosis of a cloaca. The urethra often opens inside the hymen and it is not well visualized. And these could be the other evidences: foreshortened labia minora or the anterior hymen being absent. So this could be other evidence of a cloaca malformation. And once you identify cloaca, there are several important associations which one must identify, because they could be leading to certain problems in future. So, for instance, there could be vertebral anomalies in the form of a tethered cord. There could be anorectal malformation, as is commonly a part of the cloaca. Cardiac defects could be present. T fistulas could be another associated part of the syndrome. Esophageal or intestinal atrasias could be seen, as was also evident in this child. Renal anomalies are significant associations and seen almost in 90% of cases of cloaca. This could be in the form of renal agenesis, hydronephrosis, renal dysplasia, horseshoe kidneys. And if these conditions are present, they can lead to a high risk of renal failure, sepsis, and acidosis. And many children could also have some limb anomalies. So a bacterial association is commonly found with cloaca, and this should be looked for. So, and whenever we identify such CAKUT in the initial period, the aim of the urological treatment is basically to drain the hydrocolpos, which often causes pressure on the bladder and can lead to worsening renal function. So draining of that hydrocolpos is the first primary aim. And the main aim is to surgically separate all the three tracts. So the digestive, urinary, and the reproductive tract, which is draining in the common orifice, has to be separated, and we have to create separate stomas for all of these tracts. So this could entail performing a colostomy, a vesicostomy, and the aim would be to create a catheterizable urethra for even a later normal function. And a genital reconstruction is often required to have a normal external genitalia. So when we saw this child in the emergency, she appeared dehydrated. She was mildly puffy, was mild edema. Abdomen was distended with ascites. Her circulatory, the perfusion was not very good. She had thready pulses. There was tachycardia, tachypnea. She was requiring supplemental oxygen, and the BP was low normal. Chest was clear, and we could identify rectal opening, and the urethral opening was not clearly identified and was within the introitus. So she had been diagnosed to have a renal vein thrombosis on Doppler, and we had an important we had to deal with it promptly, because she had a single functioning kidney, and the renal vein in that single functioning kidney was thrombosed or blocked. So it was kind of an emergency. So we immediately discussed with the intervention radiologist, and local catheter-directed thrombolysis was attempted. Femoral access was secured, and recombinant tissue plasminogen activator was locally infused into the thrombus. So the area of the renal vein which was thrombosed, the catheter was inserted through the femoral axis, and the RTPA was instilled, which helped in restoring the flow in the renal vein. And through the same axis, later on, a femoral HD catheter was inserted, and we proceeded with the renal replacement therapy. Because she had significant sepsis, we decided to empirically start with meropenem after taking all the relevant cultures. And so renal vein thrombosis, as we know, is major thrombosis in the major renal veins or the tributaries. It can have a varied kind of a presentation. It could be asymptomatic in certain individuals, or it can present with catastrophic complications like a pulmonary thromboembolism, or can present with a worsening renal function, hematuria, and enlarged kidney. The usual causes, as we know, are severe dehydration, prolonged hypotension, infection, and malignancy are the main causes. And in children or individuals who have a prothrombotic tendency, which could be because of the hypercoagulable conditions like nephrotic syndrome, or they may have certain inborn problems causing prothrombotic state like a protein C, protein S deficiency, antithrombin 3 deficiency. And so these conditions could be the important contributors to causing renal vein thrombosis. Sometimes we also find in some other rare conditions like vasculitis and in nephrotic syndromes like membranous nephropathy, which can have a high risk for thrombosis. The diagnosis of renal vein thrombosis is a very important thing, and often Doppler may or may not pick up the thrombus. So CT renal angiography is considered to be a gold standard, and it has to be identified quickly because it can lead to high mortality if it is undiagnosed and untreated in time. And treatment is usually the treatment of the underlying cause. And asymptomatic patients, you basically try to reduce the proteinuria if they are severely proteinuric. If it is a symptomatic patient, anticoagulation or thrombolysis is required, which could be using unfractionated heparin followed by warfarin or a LMW heparin. And if there is another condition like antiphospholipid, then treatment of that condition would be required. So in this case, also thrombolysis could be performed, which could be systemic or local, and catheter-directed local thrombolysis, as was done in this case, where you insert a catheter and the tip lies in the area of thrombus, is found to be more beneficial and has less side effects as compared to a systemic thrombolysis, where the risk of bleeding becomes significantly elevated. And this has to be usually followed up with a maintenance anticoagulation because most of these children may develop a rethrombosis in the renal vein. So in this child, we did a prothrombotic workup and everything came low. So protein C, protein S, antithrombin 3 was significantly low. Lupus anticoagulant came positive. And so we were a little concerned and little in a dilemma as to is this as two different conditions or is just because of the overall hypotension and hypovolemia that she had. And because of the thrombus, everything has got consumed and everything is now looking on the lower side. We also did a C3, C4 just as a routine screening because of the thrombus, which came low, and the ANA and other things were negative. She had an nephrotic range proteinuria when she presented to us. We started her, gave her basic hydration, and heparin anticoagulation was later on continued during dialysis. And when she was not on dialysis, she was kept on subcutaneous enoxaparin once a day. And we were doing a periodic Doppler almost on an alternate day or every 2 days just to make sure that we are not landing into a rethrombosis situation. So she looked clinically dehydrated, had a low normal BP, and we had to start her on a CRRT. So we did a CVVHDF for 3 days and using HF20 circuit and heparin anticoagulation. And we were facing frequent clotting of the circuit. And so at the end of 3 days, we had to switch her to SLED because by then the BP had improved from 18 systolic. She was touching 100 to 110. She was looking much better, although the urine output had not improved, but clinically, systematically, symptomatically, she had improved. And later on, she was kept on next 10 days for on daily SLED, where we were doing SLED with scuff, and we're trying to keep her as euvolemic as possible. She also had developed patchy pulmonary consolidation and was requiring oxygen requirement. And during one of the change of lines, she acutely desaturated and required mechanical ventilation. So that this is a time when she became acutely sick. All this while we were worried about the rethrombosis, so we were trying to keep her on at least the minimum anticoagulation which was required. But during these change of lines and all these invasive things, I think it kind of decompensated her, and she had a significant pulmonary bleed, which was evident on a whiteout lung. She also by this time was becoming more sick in terms of the ascites. Her nutrition was compromised and she was developing severe ascites. So the lungs were looking little flooded. There was also element suspicion of a right lung bleed. So a bronchoscopy was done, which identified just a small mucus plug. And so she was kept on almost next 4 to 5 days of mechanical ventilation, following which she started to gradually improve. In this meantime, she required, because of the severe ascites, albumin infusions were given while on SLED, and a therapeutic ascitic tapping was done, after which she started gradually improving, and then we could successfully extubate her. By this time, after the 2 weeks of renal replacement therapy, her renal output started improving, and creatinine started normalizing. However, the fever persisted despite 2 weeks of meropenem. So now when you have such a case where you are suspecting pyelonephritis and has a persistent fever, and the blood culture which has already grown Klebsiella, you have to be more suspicious that whether this is growing into something like more beyond the pyelonephritis. And the ultrasound which we were doing quite often started showing these renal abscesses initially, which were small pockets, but later on they coalesced to form a single large collection, which was quite significant, 60 to 80 cc of pus, which was evident on an ultrasound. And we initially tried to manage her with changing antibiotics, which took the infectious disease opinion. And she was put on a like almost all the highest end antibiotics. However, the fever was not improving, and then we had to go and do a percutaneous drainage of the pus. And initially, we just attempted a single drainage on one or two occasions, but because it was again refilling within the next few hours, and hence we had to keep a percutaneous nephrostomy tube for almost 5 days, following which the pus completely, with the help of the antibiotics and the drainage, the pus completely regressed, and then we could take out the nephrostomy tube, and then she kind of symptomatically started improving. The pus again showed Klebsiella. So this was even after 2 weeks of meropenem, the pus again was growing the same organism. So this was quite perplexing. And then she was kept on these antibiotics, which was changed periodically after the infectious disease opinion. And renal abscess subsequently resolved. So renal abscess, as we understand, is basically a suppurative collection in the perinephric space or renal parenchyma. Usually results from fat necrosis and could be associated because of the prolonged bacteremia. It is often insidious, as we could see in this case, that she had a background of fever, and it gradually, when the fever did not subside, even after giving a high-end sensitive antibiotic, the Klebsiella was sensitive to meropenem, and even then she did not have like a remission of the fever. And so when you have such patient presenting with persistent fever on the background of a suspected pyelonephritis, this could be one point to suspect development of a perinephric abscess. The common organisms that are usually found are gram-negative organisms, enteric bacilli, and Staph aureus, E. coli, and Klebsiella have been the common found organisms. Blood cultures may be positive only in 50%, and urine cultures are found to be positive in almost 45 to 70% cases. And untreated cases may land into high risk for mortality. So perinephric abscess, if it is not drained in time, it can lead to complications in the form of fistula with the urinary tract. So if you find that the pus is changing the consistency to a clear fluid, then that could be a hint that it is getting connected with the urinary tract, and then it's the urine which is draining instead of the pus. So at one point we found that the nephrostomy tube was draining a little more less turbid fluid, and we were worried whether she is developing a fistula. But then fortunately the flow stopped, the pus completely stopped coming, and then we could take her off the nephrostomy tube. So it has been said that if you have an abscess cavity which is more than 3 centimeters on ultrasound, needs surgical drainage, which could be easily done by ultrasound guidance, or at times may require a CT guidance. And if you have already developed a significant size of the abscess, a daily drainage for almost 5 to 7 days is required to clear the abscess completely. Otherwise, it often refills in the next few hours, as happened in our case. So antibiotics, it's recommended that you continue it for almost 1 to 3 weeks after stopping the drainage of the pus. So in this child, after one more complication that we encountered, that she had frequent large water stools, and because she was on all these antibiotics for such a long period, we suspected whether this is Clostridium difficile, which was not detected, and we were trying to alter the consistency of the RT feeds and the feeds that were given. And as we do normally do with all the diarrheal patients, we put her on probiotic. However, the fever persisted even after the draining of the pus. Um, she had some new onset fever, and we were quite worried about the cause of the fever. By this time, the urine output and the renal function started to improve, but the blood cultures, which initially did not grow anything, started growing this alkali halo bacillus clausi. So now we never heard this organism before, but then we did the literature search. To our surprise, it was the organism which is contained in the enterogermina. So this is a probiotic organism which she started growing regularly in her blood culture. Every blood culture which was sent started growing the same organism, and it persisted for almost 4 to 6 weeks. So we were actually quite worried. Then there was no other way to treat this but to continue the high-end antibiotics. So we had to put her on vancomycin, levofloxacin, and ultimately, when none of this worked, we had to also add rifampicin, which was added after doing a literature search, where we found few case reports where this probiotic organism starts growing in the blood culture. And they found that many of these children could have some immunodeficiency, and that could be one reason why these children are growing such organisms. And in few of these cases, they have also reported a high mortality. So we were quite worried for this child. However, luckily, the fever started almost improving after almost 1 month of these antibiotics. And after 6 weeks of the repeated blood cultures, the blood culture became sterile and this organism was no longer grown. And then we were finally able to send the child on antibiotics. After going home, she had a much faster recovery. She started doing well, started walking. She had become quite weak, malnourished, and started eating well. And the urine output started improving, and it almost like at some point she had become polyuric, but later on she had a normal output, which was almost 1 liter per day. BP improved, and there was no recurrence of fever. She has been kept on trimethoprim prophylaxis, and at discharge, her parameters were almost looking quite normal. Hemoglobin had improved. She had required transfusions on multiple occasions. Creatinine, which was 2.5, came down to almost near normal. And she still has mild metabolic acidosis, and she's on oral soda bicarbonate, but has normal electrolytes, and the urine routine recently on 2 or 3 occasions has shown a normal urine analysis without any proteinuria. The pus cells have almost normalized, and there are no RBCs or bacteria. So this basically was a case of a cloaca with a solitary kidney with severe AKI, which was secondary to renal vein thrombosis on a background of a gram-negative sepsis with a hypotensive shock, dehydration, and a pyelonephritis, which later on got complicated and developed a significant perinephric abscess. And this surprising element of the probiotic bacteria growing in the blood culture was something totally new to us. And we learned that we should have to be very careful while giving probiotics to any child where you suspect any kind of immunodeficiency. Even though if it is an acquired immunodeficiency, we have to be very careful when we give such organisms, such medicines. And so the further plan for this child would be you keep uh, periodically evaluating her renal function, because she is at a risk for going into a chronic kidney disease. She's already into a initial stage of a CKD. We will be checking her urine for UTI, proteinuria. A BP would be recorded at every visit. She will be assessed for her growth. A periodic renal Doppler. So now, after all that bleeding episodes which she had and um, all these complications, we did not keep her on maintenance low LMW heparin, because we were worried that she might develop significant bleeding. But we are keeping her well hydrated and doing her periodic Doppler, which have been shown to be normal. So the renal vein has now completely opened up, and which is also seen with a near normal renal function that she has now attained. And we would soon recheck for a thrombophilia profile, because initially everything was low. So we would see whether now all the protein C, protein S, antithrombin 3, everything has come normal. And we would also like to see a normal complement, because what we anticipate is that it was basically during that acute episode that the complement got consumed, and hence it was showing as a hypocomplementemia. We would also see her growth, and if we suspect that she needs an immunodeficiency workup, we may do so next few visits. A DMSA scan we would be planning the next few months to see what is the current situation of the kidneys. She had already multiple scars, and what has been the current function. And pediatric urology plan would be very important for her bladder evaluation. And a Mitrofenov procedure has been already discussed for a catheterizable stoma. We had a lot of problems while the admission. We were trying to catheterize her, and even the pediatric surgeons were not able to catheterize her because the anatomy was so complex, and even after repeated attempts, we could not identify the urethral opening properly. So this was a real challenging case for us, cloaca and malformation, with all these attendant complications that we saw. So I think that's the presentation. And if there are any questions or any suggestions, how we should approach this child.
Excellent case, and really managed with so much tenacity. And so that's how I think you could take the child through this difficult course. I have just one question. Any idea what prompted the managing physician, pediatrician to do the initial Doppler?
So because of the renal failure, they just did it like a renal ultrasound and Doppler. So I think that was a good thing that they did. Otherwise, the cause would have been not clear initially, because it was a single
Right.
kidney and
Because
background of
that
dehydration.
kind of,
Yeah.
okay,
So it was very nice that they did it. So the plan, we could like start promptly as soon as she was admitted.
right.
Has anybody else encountered a case of a cloaca with similar complications, renal failure or recurrent UTI, perinephric abscess? Because these are all quite we read, but once you encounter, then you find it is uh, significantly challenging to deal with. And this persistence of fever for almost 4 to 6 weeks was quite alarming. And at one point, we were quite worried that we might lose her. But luckily, with all the team's efforts, we could manage her successfully. So it was truly a multidisciplinary team involvement. The pediatric team, the infectious disease, the pediatric urology, intervention radiology had a major part to play. The dialysis team, everyone worked quite tirelessly, and we could have a good result at the end. Any other inputs from anyone? Has anybody encountered this probiotics causing problem? So normally we are so not worried about starting probiotics in each and every case with diarrhea. Now I think after that I have written probiotics for 2 or 3 patients, and I have actually cancelled because I was referring to this child while whenever I was writing enterogermin or any probiotic.
Can I make a comment, sir?
Yeah.
Probiotics is not an evidence-based management for diarrhea anyways. I
Yeah.
actually don't know what is the actual indication of giving a probiotic, or it's just for like it works as a placebo.
So actually, in a diarrhea, when you are like having profuse diarrhea, there is not much that you can offer to the parents who are also quite worried and they keep questioning. So especially when you're on RT feeds, we try to change the type of RT feed that could be given, because sometimes some foods are associated with diarrhea, and so we try to eliminate the sugar from the thing, the protein content. We were giving her some supplements to improve her nutrition, so that we try to cut out. And she was already on this antibiotic. So when you already are on antibiotics, it's usually antibiotic associated diarrhea, or it could be a kind of a some other kind of a diarrhea where apart from probiotics there is not much to offer. So I think usually a diarrhea will have a probiotic as a part and parcel of the treatment. Yeah, but after this we have become very like careful that if you can avoid it, try to avoid it, because you never know, you may land into complication. Although such reported incidences are very few, you could hardly find any. I think 8 to 10 reports so far where this bacteria has been growing. But as I mentioned, in few cases these patients have already died. So it was not all that safe to have such organism growing in your blood culture. Anybody else?
Okay. So if there are no more comments,
Yeah.
thank you very much, Kiran. I
Thank
think
you.
this was a very educative case. And thank you everybody for attending and for contributing to the discussion. Thanks. And I look
Thank
forward
you.
to people approaching me rather than me having to request people to present. So I see some new face names also. So Shrishti, and I saw some new other names as well. So please.
Dr. Srishti, Madam Dr. Srishti has done pediatric nephro fellowship from Vadia, and she's currently at our hospital. And
Okay.
there were 2 pediatric postgraduate colleagues who have joined from our hospital.
Okay.
So
Okay. So maybe those are the
Manogya
new
and
names. I can't see them anymore. Yeah.
yeah.
Anyway, I hope that somebody will volunteer to present.
Yes.
Yeah.
Thank you,
Thank you
ma'am.
very much.
Yes.
Thanks.
Thank you.